If you remember a few months ago, I made a video with Dr. Ian Grayson on how not to get sued. Now, of course, you can make an argument that one way not to get sued is not to be vlogging while on the freeway. By popular demand, a lot of guys wanted to know if we could do another video on consent and what are the best practices for filling out a chart after a patient visit. So I'm going to go visit Ian today and do that for you today. Well, guess what? I'm here with Regina. Regina is Ian's better half and cooks a mean quiche.
It's a quiche with anything you want to add to it, so it's very versatile.
Terrific.
So first I'm making the dough, which is actually quite simple. So I've got 2 cups of flour in here, just all-purpose flour, with half a teaspoon of salt. And then you take unsalted butter, 2 sticks, very soft. You see, it's all at room temperature. It's been left out for a while. You're gonna mush it all together by hand, so it becomes very crumbly, just so it's all stuck together. Season my dough a bit, so just a bit of pepper. So I have a little bit of basil. So I kind of mush it all together. 1/8 of a cup or 2 tablespoons of, believe it or not, vinegar. And vinegar, you could use water, but I find vinegar really binds it nicely. And you can see it's going to start coming together. That's why it's important that the butter is really soft at room temperature. See how it's binding? And that's going to become your dough. So nothing sticks. I always spray over a sink. Then you take this nice dough and we're gonna just spread it out, get it into a... So while I make the filling, I put this in the fridge. Preheat the oven to 350. 3 eggs, half a cup of milk. So, and this is half a cup, because a lot of quiches take more eggs, but that's more or less a half a cup. White albacore tuna, not light, because light will make your quiche brown. So this is in water, so I drain the water out, so it's pretty well just tuna. This is only 4 ounces, so I like to put 2 cans. Yeah, so just kind of mix that in. I don't use solid because then it's hard to break up. I like the chunk. Your fillings can be anything you really want. I have a mixture of vegetables, green onion, a little bit of broccoli, red pepper, about a half a pound of cheese. And I like a mixture of cheese. I also have, if you notice, a bit of dill in there because it's tuna. And then I always add a little bit of pepper. No salt because tuna is salty. Kind of mix it all together. So this takes about an hour. So after 45 minutes I check just to make sure it's kind of gelled and no liquid showing. So, and it's golden on top. So there you go, 350.
I love it.
Love you too. Bye.
Bye.
Hey Ian, thanks again for joining me. We're going to do a second installment here of that popular video on how not to get sued. Okay?
Okay.
So people wanted to know, as a way of not getting sued, what are the best practices for filling out charts? What kind of information you need to put in there? And maybe we can also go a little bit over consent forms and things like that.
Sure. Well, inside the chart, you're basically making a formal record of what you've discussed with the patient. So one of the first things you want to do is you want to review that, in fact, you did go over the medical history. So there's a little box in there, you just check it off. If there's anything that would influence your condition, you may want to make a little note to that effect. And the next thing you'd want to do is go into why the patients come in, and you want to write down in their own words what is bothering that patient.
Yeah. So obviously the chief complaint, that's the basis of all diagnosis. But the patient chart is the way by which that's the medical record by which legally we write down the information and basically our experience with the patient throughout the procedure. So anything that's not in there may have not happened by law, correct?
Correct. There's an old adage, if it's not written, it didn't happen.
Yeah.
And then it becomes a matter of your word against the patient's word,
right.
And that's never a good situation to be in.
But in terms of the stuff that you are for a typical endodontic I mean, a consultation will obviously would have to have all of the presenting, the chief complaint, the patient interview, including any of the specifics of the past medical history, past dental history,
Right.
as well as the medications and things like that.
Right.
And then it's going to have the clinical exam results.
Right, and most of the time that's in the form of a template. So you write the standard versions down. You write down your temperature testing, you write down percussion, palpation, bite test, and periodontal conditions. Those are the conditions that you want to look at for each tooth in the quadrant that you're examining. And you certainly put a plus or minus within that template to indicate that you've gone through it. And then right under that, you'll arrive at a diagnosis. Your diagnosis will be a pulpal diagnosis, and your diagnosis will be a periodontal diagnosis. And then right below that, you're going to write down the prognosis. And the prognosis will very much depend on a number of factors: sizes of lesion, presence of resorptive defects, if there's a fracture detected in the tooth. This will all influence how the prognosis will come out.
So diagnosis, treatment plan, prognosis, and in the treatment plan, you give patients options in terms of what are some of the possible options, A, B, C,
Right.
as well as alternatives to no treatment, including that.
What
correct?
can happen if you do not do the treatment? Obviously, if it's a serious infection, it can in some cases be life-threatening, and that has to be documented in the chart.
So using a matrix of pulp vitality testing and all of the clinical examination to arrive at a pulpal and apical diagnosis, and that's the key thing.
Right.
For endodontic diagnosis, you need to always have two different diagnoses: pulpal, what's in the pulp, and then apical, what is happening at the apical level.
At the apical or on the lateral portion of the tooth too. Sometimes these lesions will extend to the furcation, sometimes it will be lateral to the tooth. It'll give you an indication that potentially there's a fracture. If you note that there's a periodontal pocket which goes from the gingival sulcus right down to the root tip, there are one of two things it can be. It can be a fracture, or it can actually be a periapical problem, which instead of draining through the gingival tissue is draining through the sulcus. And it's an easy way to determine which one is which.
Awesome. And I think it's probably a good idea. What I'm going to do is I'm going to share with you guys my own personal charting system that I use at my office. And that could be helpful because, it has to be quick at the same time. Your assistant could be checking it off as you're talking to the patient and basically finding things out. Your assistant's there taking notes and then checking these off. It's better to do it immediately as opposed to wait till the end of the procedure, because then you may be rushed to go to the next patient and then you're going to kind of skip things.
But very, very important at the end of the day, even though your assistant has been writing it down, they all have to be verified by you. Every once in a while, the assistant will misinterpret something and it's not quite the way you want it. So the bottom line is every dentist should go over and validate all the information is correct.
Yeah, for sure. And so, by the way, for the treatment, for example, the concentration and the amount of anesthetic and all of the things that you use, materials that you use for filling the tooth, as well as any specifics for irrigation material and all that stuff.
Right.
Everything has to be written down in terms of the chemicals and materials that you use, right?
Chemicals, quantities, and the technique that you used. If you use warm vertical, fine. If you use lateral condensation, fine. If you use single cone, fine. But it should be notated within the chart.
Right.
Also within the chart, you should note if there were any complications. If, for example, while looking for the canal, you perforated a section of the tooth. Well, you did a BC putty repair with BC sealer, it should be notated and exactly where that perforation was and the size of the perforation, because ultimately that may influence the prognosis, and certainly the patient and the referring dentist should be advised to that effect. And then after you finish your treatment, again, so you'd have a prognosis when you do your diagnosis, and you'd have a prognosis which may change or may be the same when you finish the treatment. If it turned out better than you thought, obviously the prognosis might be elevated. If it turned out worse than you thought, if you couldn't get to the apical area, the prognosis may decrease. And you'd have to write in the chart that potential surgical intervention may be necessary at a future time.
Right. And also some of the issues such as, how many canals were found. Was there a search for example, on a maxillary first molar, a search for MB2 was conducted, but it was not found.
Right.
If a canal was calcified, your attempt to get down that canal so that it doesn't get interpreted later on as though it was essentially missed. Or you had not attempted.
Right.
And how long of an attempt was made as well. Those are all going to be helpful in terms of giving a context, in terms of what you did clinically, in terms of attempting to find canals. Was patency achieved? Was patency not achieved? And their effect on the potential, on the prognosis of the tooth.
And the outcomes.
All of those
yes.
are important factors as well.
For sure. And all that information should be relayed to both the patient and the referring dentist in order to make sure that everybody's on the same page. So if the patient has a problem in a couple months, he's not going to come back and say, oh, I thought I had a root canal, it was fine. No, he understood that there was a potential problem, and it makes it a lot easier to go into the next form of treatment. You know, you're not going to get into risks which are totally ridiculous, like paresthesia from an injection.
Right.
You're not going to discuss that. But if you're looking at a tooth, say a lower second molar, especially on a female, where the inferior alveolar is very, very close to the apical area of the tooth, you have to disclose that there's the potential, if you get down there, that there may be some nerve involved.
Yeah, so the discussion of risks for the procedures that we do is an important one too. That part of that goes into the consent form,
Yes.
and then part of it's going to have to be written in the chart. Probably the part that's in the consent form is the important part. But I found that my consent form, which I'm actually also going to share with you guys, is basically very simple, because I found if you write every potential risk in there,
It's overwhelming.
they're not going to read it, and some people are going to unnecessarily get afraid, and because
Yes.
people don't have a context in terms of the percentage of risk.
Right.
Plus some of these things such as like broken instruments and things like that, any other risks that you sign off of, they're not necessarily going to uphold in a court of
They
law.
won't exonerate you. If you use bad technique, a consent form is no defense.
Right.
Just because you told them it could happen, if you jumped from a number 10 file to a number 30 file, incorrect technique, and you severed the 30 file in the tooth, because you told the patient this could happen, doesn't mean that you're absolved of any kind of guilt.
Exactly. I mean, best practices are still, no matter what you write down in there in a consent form, best practices still stand. And the question is always, what would under ordinary situation, a competent
Reasonable.
physician or reasonable dentist do, correct?
In that set of circumstances.
In those set of
And
circumstances.
that's the test that it must pass.
Yeah. All right, so Ian, I know that you're now kind of on the brink of retiring as well, and kind of finishing up with Endo, and might be leaving us here in Boston, heading up to Canada. Do you want to tell me what's your game plan? And also as a broader thing as it pertains to other dentists out there, how can people really balance out this work, retirement, and leisure kind of balance in life, and so that they can get the most out of this situation?
When it comes to retirement, when it comes to the transition between working full-time and potentially working part-time, or working full-time to go to complete retirement, I think the most important thing is to have a plan. It has to be something that you've thought about, that you can implement as soon as this transition starts to take place. And for myself, I have a lot of interests outside of work. Certainly making these videos is one of my interests. I love making these videos with you. Certainly teaching, I'll become more involved in teaching as time goes on. These are things I love to do. Sports, I love to play squash. As you know, that's very, very much a large part of my life. My family is growing. Certainly I'll spend time with my family. These are all things that I can segue into once I stop or reduce somewhat my working activities. However, I still like working too.
Yeah. So, I mean, it is really about planning on the retirement. And I've had colleagues who retire working and doing the stuff that I do. And I always said, like, look, I mean, work does not necessarily, retirement doesn't mean you cannot work, period.
No.
If you really enjoy what you do, and that is, for example, doing endo and helping people get out of pain,
You can
and
still
so
do
on.
it a day or two a week so you can keep yourself involved in the profession.
Right.
But at the same time, there's more than enough time to do the other things that you've always wanted to do. Maybe you want to travel.
Right.
Maybe you want to go skiing and become a better skier and take lessons and really work hard at it. There's so many things that you can do. There's a lot of opportunity out there that you can partake in this kind of thing.
I mean, I think the concept of retirement really is one that has been confused in the popular vernacular, where people think that retirement means you're just going to go away. You go somewhere, maybe
Right.
down to Florida, wear these big pants, and maybe play golf all day long.
And discuss politics.
And discuss politics. And I think it's just a big mistake, because to me, retirement is basically just purely a term in terms of financial retirement, which means that you're just not working to support yourself on a regular basis.
But you're still working at something. You're going from one activity to another activity. And the problem with a lot of people is if they go from one activity to inactivity, that's where you run into problems. That's where you hear about the stories. Well, someone retired and within a few months he became ill, or within a few months things did not go well for him, because the segue towards working for monetary reasons and working at something else was not a good transition. You can't go from working to doing absolutely nothing. That's a recipe for disaster.
No, absolutely. I mean, life is a constant process of learning and improving and working and applying yourself. And that's how we kind of find meaning in life, in a sense, right? I mean, the old saying is that, you know, you don't stop learning when you grow old. No. You grow old when you stop learning.
Yes.
And that's really the whole point of it. So I think we're on the same page in this front. But I just want to emphasize that, you know, many people think that they have to go play golf or do some of the habitual activity. For many people who really love what they do, their work and their job is their hobby. And that's probably the best kind of a position you can be in if you have managed to get.
But the problem is, at some point in time, your skill level drops off. As we age, it's a natural progression that our eyes, our hands, our back, everything tends to drop off. And it's the prudent practitioner who understands when they reach a certain point, when they can't deliver the service that they want to or expect to deliver, at that point in time, there becomes time for this transition.
Yeah, without a doubt. And I think it's important to be able to extend your career, if you will, if you're really enjoying it, by taking better care of your body and doing different things, and then being able to kind of manage the amount of time you spend doing patient care versus other activities that helps you know, grow the required muscles and the muscle tone to support you.
The most important thing, and I'm going to harp back on it, is planning. If you know that you have a horizon where you're going to retire in 5 years, at that point in time, you should be getting into those activities that you plan to do post-retirement and develop a pathway to get to those things. So when you do retire, you simply go from one activity into another activity. There's a smooth transition. So there's not that drop off where you're working, all of a sudden nothing. So you go one to the other, and it's very, very smooth, and it's very non-traumatic for you.
Yeah, that is true. Well, I'm retiring in a couple of years. I'm certainly going to be following your advice on that front, and hopefully be able to get to that next phase and find that right balance of enjoying myself as well. But it's been terrific, man. It's we're gonna miss you if you're gonna go up to Canada. Hopefully we'll get a
come
chance
up and visit.
I definitely
Part
will.
of your retirement, visit Canada.
Actually, I do have family up in Canada, so I should come more often and visit. But once again, it's been a pleasure, and I think the quiche is probably ready now too.
Oh yeah.
Let's go and enjoy that.
Great. Thank you.
Thanks, man.
Okay.
Wow, that smell.
Ooh, perfect. See, it's golden.
Look at that.
That is impressive.
You gotta let it sit for like 10 minutes so it congeals a bit.
I cannot wait.
Salivating.
Some salad?
Oh, you see my tea cut. Yeah, I brought out my best china.
Oh, the paper.
What a job, Regina. That's awesome.
Wait a sec, what about the cutting?
The broccoli is actually really interesting.
He's like beefiori.
You know, it's funny because the tuna is not overpowering at all. You would think that you know, you would taste tuna, but it's not. This gives it actually a nice sour taste, and I think that mayo is a nice way. It's kind of mixing up a little bit of creaminess with a little bit of dill.
You taste the dill, eh?
Because it doesn't taste like an omelet. That's the key thing, is that it has a very unique flavor.
Well, it doesn't have very much wet ingredients.
Wow,
that's amazing.
That's pretty good. Worth the drive to Roslindale.
That's right. Well, that was great to see you again. Likewise. Thanks for everything. All right, I'll see you hopefully soon. All right, that was a great little get together, and that quiche, you gotta have to make it. That's incredible. Regina's recipe is just amazing. Just great people. This guy is just great. I love him. He's just such a great guy. Great and honest, and a great human being.